Good afternoon. My name is Summer Wiley. Welcome to my collaboration and leadership reflection video for Nursing FPX 4010. This video will present and reflect on interdisciplinary collaboration experience, noting ways in which it was successful and unsuccessful in achieving desired outcomes. It will identify how poor collaboration can result in inefficient human and financial resource management, identify best practice leadership strategies from the literature that will improve an interdisciplinary team's ability to achieve its goals, identify best practices interdisciplinary collaboration strategies to help a team achieve its goals and work together, and cite the authors used in the literature. I will present an interdisciplinary collaboration situation that happened when I was requested to help create an updated scenario, background, assessment, and recommendation communication tool called the SBAR tool. A little over a year ago, I started working in women's services, prenatal, labor and delivery, neonatal intensive care unit, and NICU, postnatal care, all provided in women's services at Villa Health. I was majorly based in the antepartum unit, where I worked as an antepartum nurse. My main task was caring for women who were having pregnancy-related difficulties but were still preterm. Some of my major responsibilities included fetal monitoring and bedside care in a primary care environment. Whenever necessary, patients and members of the multidisciplinary teams would also participate in the process of reviewing the care plan as needed. There have been some issues in the women's department services, specifically regarding how accurate communication was being used when patients were being transferred, whether over the phone or at the bedside. For instance, at one of our committee meetings, one of the raised issues was leaving out important information during the transfer of a patient from one unit to another. Due to this, the nurse in charge of admissions was sometimes not getting adequate and relevant information, making it difficult for them to complete admissions in a timely and organized manner. In most cases, the admitting nurse had to spend time searching through the patient's electronic medical record to get particular information about their medical history. Depending on the situation, the patient's diagnosis, each department had a unique SBAR that they use. However, in this section, patient admittance and treatment were delayed as a result of the SBAR tool being utilized incorrectly during the communication breakdown. The educator in charge of women's services sent out an email discussing the revision and updating of the SBAR tool sheet so that it could benefit all the units in this department. To prepare for this meeting, everyone was given a SBAR tool sheet to review and note down any thoughts or suggestions that they had. The educator, the unit manager, PCC, and a nurse from each department attending this meeting, everyone was given 3 SBAR tool sheets to review. We run through the samples and discuss the advantages and drawbacks of each one before deciding which one to use and making any required adjustments. Within a week, each department had its own SBAR communication tool sheet. Successfully updating the SBAR communication tool assisted in promoting interprofessional collaboration, improved the framework for effective communication between departments, and it reduced the time spent in the transfer admission process that delayed patient care. This updated SBAR tool also eliminated the use of multi-SBAR tools, which was the contributing factor to the controversy within the departments. The idea of revising and updating the SBAR tool did promote interprofessional collaboration and more. However, there were unsuccessful ways that limited the full achievement of the desired outcomes, such as not all healthcare professionals of the interdisciplinary team were engaged in the planning and development of the new SBAR tool. Therefore, not all healthcare professionals were easily accepted and adopted the new tool. Also, there wasn't an in-service session or a training offered to the healthcare professionals so that communication and the use of the SBAR tool were well understood. Another undesired outcome was that most of the interdisciplinary team described the new SBAR tool as cramped and difficult to understand. Shahid and Thomas noted that SBAR is a reliable and validated communication tool that has shown a reduction in adverse events in the hospital setting, improvement in communication among healthcare providers, and promotion of patient safety. Therefore, after months of revising the tool and involving every individual in the revision process, the revised tool was designated with only the most significant and similar information between the departments, and it was easy to read and understand. The overall outcome was achieved by establishing interprofessional collaboration toward promoting effective communication and increasing patient safety. After carefully examining the scenario in the Villa Health activity, I discovered many in which poor collaboration amongst the interdisciplinary team resulted in ineffective management of human and financial resources during the facility's electronic health record system change. During the interview, the administrator and the director of operations complained about the notification for the upgrade and being excluded during the decision-making and purchase of the new system, which led to a design that wasn't compatible with the hospital setting. The IT manager expressed that his department too was excluded from the involvement and installation of Healthix. The external training coach, who was unfamiliar with the staff, refused to listen to both management and care staff's concerns and advice concerning the system's defaults. At the same time, the care staff complained of the lack of proper training and assistance on how to use Healthix accurately. This led to stress, conflict, decreased morale, and disengagement of the care staff. This put them at risk of patient safety because the staff was not appropriately using Healthix when charting the patient's plan of care. The need to improve profit required a limitation in costs. Therefore, the corporate neglected to apply interprofessional collaboration in the decision-making for Healthix. They did not incorporate either management or the care staff's perspective in selecting the EHR system. Instead, the corporate chose a system that was inexpensive and designed for a larger organization. This led to income investment and time towards a system that was not suited for the facility's issues, resulting in an unsatisfactory EHR system and an unsuccessful system transition within the nursing home facility. The ineffective collaborations identified resulted in an unsuccessful system merge, an outcome due to ineffective interprofessional collaboration and ineffective communication amongst the disciplinary staff. In other words, there should have been better coordination between leadership, administration, IT, and the nursing staff. This is because the process failed and was due to inadequate collaboration. A decision on which software to acquire should have been made with input from IT manager. Also, nurses should have been sufficiently trained to improve patient care. This would have been a more successful venture if an interdisciplinary collaborative team comprised of nurse management, information technology management, administration, and the head of operations were included in the decision-making process. A better leadership approach to assist the team in accomplishing its operations and operate more successfully together would be the implementation of a person-centered leadership model. According to Lynch, leaders should listen to the staff and experts in the health facility and consider their interests. The PCLS framework would be effective because it will provide an opportunity for the leader to learn about the challenges, the needs of the facility, and whether the new system will function appropriately for the care staff, ensuring a smooth and successful system transition. The author also explains the effective collaboration should apply a person-centered situational leadership framework to capture core attributes of leaders that enable team building, individual centeredness, shared vision. The balance needs to comply with the needs for person centeredness, relate people with actions, impress actions, and listen to other people and unify them. Additionally, a better practice interdisciplinary collaboration strategy to help the team achieve its goals and work effectively would be the application of a team-based learning collaboration. The publication presented by Fezzi forms the foundation of the TBLC in learning new things. I agree that the TBLC is beneficial since it might contribute to deep learning, long-term information, retention, and improve performance in terms of the multidisciplinary staff's practical knowledge. Also, better understanding weak points and ensuring that the staff fully understands how to use the system accurately may result in successful system merge and adequate use. As Fezzi and colleagues explain, TBLC is a learning-centered method that can be implemented in integrated educational programs and interprofessional training in different disciplines. This reflection gave me more insight into how a project might undergo instability, ultimately collapse due to poor communication and inadequate collaboration. According to research on Villa Health Network, it is evident that poor collaboration and communication may also contribute to dissatisfaction in other aspects of the organization.